am Yashada Tade. I'm a second year DNB postgraduate. I welcome you all to Powwow 30 March edition, in which we have cataract as the subject, and we'll be discussing cases on anterior segment in cataract surgery. Now I welcome Dr. Shiva ma'am to introduce our panelists and our presenter.
Thank you, Yashita. Thank you. And good evening, everyone. I'm really excited about this powwow because we have the luminaries of Shankanetrale alumni, and we have a real hidden gem, Dr. Sagar Bhargava, who will be presenting. He is a fantastic surgeon and a fantastic clinician, and he has an expertise of I think SN is usually we focus on a single specialty, and he is the rare one who's done quite a bit. I mean, like, he's specialized in glaucoma. He has done a little bit of, I think, oculoplasty also in cataract. He is just amazing. I've had the opportunity of interact. We were together in Shankanetrale, Navasuja, in the initial days when Sagar was, just starting with phaco, and it was very clearly seen that he's a very, very gifted surgeon. And I'm really happy that he's going to present the cataract interesting cases today. Sagar was with us at Shankanetrale till some 13 years back when he moved to Kolkata, and since then he is in a group practice at Netralayam at Calcutta. And we also have PP ma'am, Dr. Prema Padmanabhan, and Dr. Mohan Rajan sir. So everybody knows this is an alumni, Shankanetrale alumni academic meeting, and each and every alumnus knows Dr. Emma, Dr. Mohan Rajan, and I'm very, very happy that sir is able to take time out. Both PP ma'am and sir have been able to take time out and join us. We'll also have Dr. Ashok Rangarajan. Again, all those people who have got trained, when I got trained in cataract at Shankanetrale, they would know Dr. AR because he was in charge of training all of us. I think, Sagar, your time also, Dr. AR.
Yeah, he was there. He was there.
So he'll be joining us. I think he's already joined, and really very happy to have all of them today to discuss some interesting cases that Dr. Sagar Bhargava is going to present. So over to you, Sagar.
So that, can I make a comment, Shikha?
Sure, sir.
Sure. Let me thank you for the wonderful opportunity, but also I would like to compliment you, okay, for doing this consistently and very successfully as well. The Powwow series, which has been a very, very enlightening series for all of us. I think this is the 30th episode, and it is really fantastic. Hats off to you guys.
Thank you. Yeah, it's a group, sir. So that's why it's going on. There's a lot of support from our multimedia, and there are a lot of the postgraduates, everybody. Yeah, we are happy that we are able to continue with this. Thank you.
Thanks for that.
Good evening, everybody. At the outset, I'd like to thank Dr. Shikha for this opportunity, and really thank you for the kind introduction that you have done, and really took me to my my early training days in SN. Way back, we started in Navsuja together. It was very nice time at that time, learning things, learning the tricks of the trade. And indeed, it's a great honor to actually present before PP Madam, one of my mentors who have been, whom we saw and learned the basics of cataract surgery, and still, get goosebumps of thinking when Madam operates, how meticulous she will do everything. And of course, Dr. AR, who is also one of my mentors, right from my first case in Navasuja to even now, whenever I find difficulty, I always dial him what to do next. And thank you, Mohan Rajan sir, to take out time and be here. So I'll be sharing my presentation in some interesting cases. So let's go ahead. So let's move on to the first case. So this is a patient which I have titled as restoring the optical surface. So this patient is a 64-year-old male who had come with a decreased vision for last 2 years. There was a history of firecracker injury way back in 1989, after which patient had a raised IOP and underwent a trabeculectomy at that same very moment. In that, so patient basically is a status post trabeculectomy patient, and the left eye was absolutely normal. The right eye had a vision of 618, slightly irregular pupil. There was a bleb, there was a temporal dialysis, there was the CDLs was of course negative, and there was glaucomatous optic neuropathy. So essentially we are dealing with multiple things here. So this is the clinical picture of the patient. So we can very clearly see it's a large bleb which is kind of overhanging on the cornea, almost encroaching about 3 millimeters into cornea, and it's a mid-dilate pupil and a grade 3 cataract, and we can clearly see that there is a iridodialysis there temporarily. So when we did the biometry for this patient, this was what the stats showed us. So straight away we can clearly see that there is significant astigmatism in the right eye. Even the left eye had astigmatism, but there was a gross difference of almost 3 diopter inter-eye asymmetry. So probably this constitutes our first red flag. Now, the clinical decision that we need to take is whether this patient is a right candidate for toric IOL. We need to decide whether it's a regular versus irregular astigmatism. Secondly, the biometry that we did, should we rely on that? Because the K1 in the right eye was unusually flat, which possibly indicates that there is a bleb-induced corneal distortion. And again, the K disparity, which we spoke about. And then the next step is, what do you do, a single step procedure or do a 2-step procedure? So for all this thing, we need to actually do a corneal topography to see what exactly is happening to the cornea. And if you see the cornea now, this it's very clear cut. You see the corneal map there. We can clearly see that there is a asymmetric bow tie with superior flattening, and even you can see the skewing of the axis here. So we are looking at irregular astigmatism, and if you look at certain subtle findings in the report, we can see that the higher order aberration is quite high, 3 times the normal levels, almost 1.096. Astigmatism is quite high, as it is now confirmed, and even the TCRP astigmatism is also quite high. So it becomes very obvious that we need to do a bleb excision before we go on for the cataract surgery, for the simple reason that we are not getting an accurate biometry, because the bleb has distorted the cornea, and we obviously it's an optical distorted eye, will get an unpredictable refractive outcome in this patients. And second issue is that even if you do if you just do a cataract surgery in this patient and put the best of lenses, the patient will not have a good vision quality because of the higher increased higher order aberration, especially coma entry falls. So patient's vision quality will be highly compromised, and obviously this is not a good candidate for a toric IOL because the astigmatism is irregular. So we went ahead and did a bleb excision in this patient. Now, bleb excision of this, the idea of doing bleb excision is to remove the influence of the bleb from the cornea. Bleb excision is actually not a very technical procedure. It just involves separating the bleb from the cornea. It comes out very easily because the plane is quite well defined. You just have to find out the plane of dissection and bluntly dissect it out, and then basically just use scissors to cut at the margin of bleb and the healthy conjunctiva. So as we remove the necrotic bleb, what we see inside is that there is a little bit of exposure there. So there is a little bit of iris prolapse there. So we are just right now undermining the conjunctiva so that the closure becomes easy. And
what was the IOP, Sagar?
The IOP was well controlled, sir. The IOP was in the normal range only. So IOP was not the issue. Post trabeculectomy, the pressure got controlled very nicely, actually. So, and even the optic nerve was quite okay. About 0.7 was the cupping. So it was quite okay. So here we are basically just giving 3 sutures to the opening. We were made sure that we are not doing excess tightening. We just wanted to close that gap. And then, of course, the scleral patch graft to cover this whole thing up. And then the closure. So this was the end result. So the bleb was completely closed. So obviously after 8 weeks, when we repeated the topography, so we can clearly see that there is a perfect normalization of the cornea. And when we looked at the parameters, so if you see the pre and post, so there is almost 5.3 diopter reduction in the astigmatism, both in SIMK and TCRP, almost 90-91% reduction. Then in terms of the higher order aberrations, almost 65% reduction was there. It came to now 0.38. Even the K mean, which was 41.8, has now become more regular as to 44.2. So all these parameters in 8 weeks became almost normal. So we were now ready to go ahead with the biometry, and this is what we found out. So the initial biometry gave us a value of 28 diopters of IL power, and now after 8 weeks, we can see that the astigmatism is just 0.9, and we are getting an IL power of around 24.5. So in this case, it's a borderline toric. We did offer this toric IOL for the patient, but the patient was not very keen because he wanted to wear glasses. So we went ahead and selected a 24.5 Technis 1 IOL, and of course, because it's a glaucomatous optic atrophy, so we did not optic neuropathy. We did not offer a multifocal lens. So this is how the surgery went. The post 8 weeks bleb excision. So the pupil obviously needed hooks, so we basically using hooks to give us a complete view. And then of course the procedure was not very complicated. It was a standard cataract surgery. I will just try to fast forward this. So this was a grade 3 cataract. Came out comfortably without much of an issue. So I'm just forwarding this. Then we have put the lens now, and then we proceed for the iridodialysis repair. The iridodialysis repair was done with with double-armed tenoproline suture. A tunnel was created, and about 1.5 millimeters from the limbus with the railroad technique with 2 needles. We basically just got this iridodialysis repaired. And so this was the repair, and finally at the conclusion, this is how it looked on table. So so both the parts was over, and this is the patient's post-op review. The on table as on-set lamp. The patient had a stable lens in situ, and the iridodialysis repair also has been repaired. So this is the pre and post-op image, and this was the post-op refractive outcome, where we can see that there was a very minimal sphere cylinder. So the BCA was 6/6, and with a very low residual refractive error. So from this case, the key takeaways is basically any bleb, which is a long-standing in nature, can have an effect on the biometry, because of the distortion that it can do the cornea, and eventually you might get an artifact in the form of very high astigmatism. Secondly, the pentacam helped us to know that there was a significant higher order aberration values, which actually indicates that there is a full thickness corneal distortion. And in these scenarios, two-step protocol actually works very well. With an interval of 8 weeks, all the abnormal parameters came down to the normal levels and ultimately helped us to achieve an excellent functional outcome. So this was my first case, basically explaining the fact that 2-stage sometimes works better than doing a single stage with a good refractive outcome. So I think this is open for discussion.
Yeah, I think we can discuss this case first and then quickly move to the other case, because then we'll remember. Any comments?
Sagar, Ashok here. Can I just see the photograph? Do you have the photo of the one with the bleb affecting the cornea?
Yes. Yeah.
Oh, okay. Yeah. Great. So yes, I would think you are talking about doing 2-stage. That means bleb excision separately and then cataract surgery, right?
Correct.
Yeah, I would think so too, because otherwise you will have those corneal readings will come up normal.
Sagar,
Yes, sir.
Nicely done. Only thing is, this bleb, of course, requires revision and excision. There's no doubt about it, and you did it so very well. You staged the surgery between the first and second for about 8 weeks, and then stabilized the cornea and did the thing. And iridodialysis repair also is really fantastic. And what I would also do is I will just do one single pass 4-throw pupilloplasty in that area temporarily, where that is near the iridodialysis area, so that I'll make the pupil a little more round as well, so that even the excess glare or whatever it is to the patient will not be there. And only because the distortion was so much, otherwise if the large bleb the distortion is not so much on the cornea. If it's only about 2 or 3 cylinders, I will straight away do the cataract surgery or whatever it is and leave the bleb like that. That is
Right, sir.
slightly
Yeah,
different.
that's what most of us do, because seeing so many glaucoma patients, we hardly think that bleb can cause so much of distortion.
Yes.
That's the reason why I wanted to present this case, that even blebs can
So
distort the cornea.
more than 6 cylinders you got, and
Yeah,
higher order abrasions on the cornea as well. So I think it makes more sense to do the bleb excision, and you did so very well. It is also an encysted bleb, I think. You saw that.
Yeah.
And I'm surprised that because of that, this thing, there's no leakage. And
yeah, there was no leak. We
no
checked on that.
there's no
Yeah.
hypotony because of that.
No. Because the iris plugged the whole thing, sir. The stroma was plugged for the iris.
Because
So
of
that's
that.
the reason. Yes, sir.
So Sagar, how did you confirm that? I mean, like, how did you assess pre-operatively to plan the bleb excision? Did you do any kind of workup? I mean, like some ASOCT, UBM, or anything?
No, nothing of that sort is required, because generally we do a lot of bleb excisions for leaking blebs. So these blebs basically are straightforward. We really don't
here,
have to do
what I meant was like, how did you? I mean, like the glaucoma. You felt that it was a burnt-out glaucoma.
Yeah.
So I mean, like if you're excising a bleb,
Yes.
won't there be? I mean, like the patient will be put on anti-glaucoma. We also have Dr. Mohan here with us.
Yes. So I'll tell you one.
The glaucoma part, how is it? There are 3 things to it here in this case. Very interesting case. There's cataract, there's glaucoma, and this cornea.
Yes.
Cornea, you've shown. I mean, like that removing the bleb has taken care of the deformed cornea. But the glaucoma part, it will be nice to have some comments from Mona. I mean, like, how do we decide that this bleb can be removed and glaucoma is not going to cause any further damage?
Yeah, that is a concern we have. No, we remove the bleb.
Yeah. Now, that's always a concern when you touch the bleb. But this was one thing I would like to say is it is a beautifully done surgery, and very good that you staged it. And here, this was a 1989 done trab, which was probably limbus space. That's why you had that ring of steel, thin bleb, overhanging bleb, which are known to cause this dysthesias and overhanging and astigmatism. And even there was no flap. If you see, the iris was just exposed. That means there was a lot of melting there. So these blebs we usually do excise them, because they are also risk factor for future blebitis and endophthalmitis, bleb-related. So we excise them, and Dr. Sagar sutured it up. That additionally helped in taking care of the astigmatism, I feel, because the sutures, he closed that opening which had where the iris was gaping, and then he put a patch graft. So along with the bleb excision, that also probably helped with the astigmatism. Usually we have bleb dysthesias where we do excise these blebs, and surprisingly they don't leak that much, and we usually put a patch graft, and sometimes we even lift it off, like Dr. Sagar had lifted with the spatula. We don't even remove the conjunctiva, we just cut it off. Even then, because it's a sponge, it doesn't leak. Like, you may feel that when we lift it, we just cut it like this, it will ooze. It's actually like a sponge, it doesn't leak. Maybe a day or two we get a VCL, but they do very well actually. If it's just overhanging, it's just hanging on the cornea. In this case, of course, there was a gape also which needed to be closed, and this was nicely done.
Is there any pre-operative diagnostic thing to find out whether there is any opening or any defect in the trabecular in the area of the underneath the bleb?
That's a good point. So usually you can do an ASOCT, but we clinically also we can see, but ASOCT is a good option to do.
Can gonio reveal anything?
In gonio, it may not be visible because of such a overhanging bleb. You may not be able to actually see the superior angle, but it may show that communication if you can get it.
Very well done.
What about UBM?
In such a thin bleb, UBM will not give any additional information you basically need for the ostium. UBM tells more about, if you want to know about the posterior behind the ciliary process or the lens zonule status. In ASOCT, you will get the information. UBM will be difficult to do and risky to do in these patients actually, because it's a
true.
Possibility mitomycin was probably used in this case.
And it was possibly a limbus paste, like the old method of doing, which led to such kind of blebs.
It can be
Now with
excised.
the phonics paste, it's better.
Mona, I just want to know, can we excise the bleb from the posterior aspect than the anterior aspect?
I always start anterior only if it's overhanging. If it's not overhanging but it's thin, cystic, and leaking, then we do what the second part of Dr. Sagar surgery, when we excise the conjunctiva and then remove it.
Okay.
So if it's not overhanging, we can do that. What you're saying,
do that.
And then bring the conjunctiva tenon forward and put a patch graft if required.
One more question. Here you did not have a residual astigmatism which warranted a toric IOL. If there was, like 2 or more, or like 1.5. So after how many days would you recommend to do a toric IOL? Like right away we can go ahead? If it was not
8 weeks. 8 weeks is sufficient. We can actually, if the patient would have had more than 1.5 or even 1.1, I would have been, I would have tilted towards a toric IOL, definitely.
So whatever corneal molding has to occur, it occurs in 8 weeks.
Generally 8 weeks. There is a paper also which says
protocols are similar to Shikha. When you have a big pterygium, okay, and you always excise the pterygium, do an autograph for that, and then wait for I wait for 8 to 12 weeks. Normally, that 8 to 2 to 3 months period is a period between the cornea heals, and then you will be able to get a better biometry, keratometry, and all these problems can occur, because everybody thinks only the keratometry changes, but even the axial length will go. When you have distortion of the cornea, either because of a pterygium or overhanging like what he has shown, that alters the axial length as well. So it's not only the keratometry. So I think we have to look at it, because otherwise you'll be end up in putting a wrong power for this patient. We'll have a refractive exchange or the postoperative refractive surprise for these patients.
PP ma'am, your comments, please.
Nicely done, Sagar. Of course, this case had clearly cicatrized bleb. But how would you to distinguish between a functional bleb and a non-functional bleb? I think the ASOCT has a very important role and clearly delineates the ostium. So that would be a good. I agree with Mona that would have been a good pre-op imaging that would help us understand what the anatomy behind the bleb is likely to be and whether it's functioning or not. Because if it was a functioning bleb and now you have sealed it, you will have to obviously monitor the intraocular pressure more closely and be prepared for alternative treatment for glaucoma.
Yeah.
Thank you, ma'am. Thank you. We'll move to the next case.
So my second case is titled "From Radial Tear to Restored Rexus: Capsular Healing After Toric IOL Implantation." So let's see. This is an interesting patient who came to me. He was an ex-army veteran, 85-year-old gentleman. Wanted his bilateral cataract surgery to be done. First time we did uneventfully, implanted with the help of flax. We did a Clarion toric in the first eye. Landed up with a plano and a 2.5 ad. And the whole this case is for the second eye. So second eye also had grade 2 cataract, and vision was around 6/9, and we basically planned it for flax. Now the interesting thing about this gentleman is that some friend about 30-40 years back gave him this glass, which is about 2.5 diopters, and his only condition was that post surgery he should be using this glass, because still now he was not able to use this. So that was his main condition, kind of threatened me with this point that you need to make sure that I need to wear this glass. So with this stress in my mind, I did the second eye surgery. Very clear that he wanted a flax. So this was our early days when we started doing flax, and unfortunately this gentleman the pupil did not dilate well. So we went to the extent possible with for the capsular rexus. Obviously it was small. So we intended to enlarge the rexus after using the iris hooks on table. When we put adrenaline, it dilated well. The other eye, there was no issue with regard to the pupil dilation, so it went on very uneventfully. So here we can see the sextants that we had created with the help of a femtosecond, and we are now trying to increase the capsular rexus size. one of the things that I realized in this scenario is when you are doing enlargement, the glow which we thought should come comfortably was very difficult to get because of the bubbles which had formed because of the femtosecond. So enlargement was a little tough, but somehow we managed to enlarge the capsular rexus opening, and then we proceeded with the case as usual. So this is the enlargement done with both cystosome, and then we went ahead with the procedure of cataract surgery. Now, cataract surgery per se was not much of an issue. We were able to divide those sextants comfortably, and then we were able to remove these pieces one by one without too much of an issue. Now, this is the point which I want you to see carefully. This, you can see the rexus comfortably. I was saying that everything was fine. The rexus is pretty okay. We were doing polishing, and then that's the point which I missed. So if you see on your screen towards the right side at say around 2 o'clock, between 2 to 2:30, there was a small nick in the anterior capsule which I missed. I must accept this, that I missed it because I only saw it on the video. So as I was
you have to play it all over again. Yeah.
No. I'm just forgetting it.
Okay, fine.
Yeah. So this is the point where we left. So I went ahead and put the lens. This was supposed to be placed at 9 o'clock position. And that's when I realized that there is a tear. So the good point here was that I had to put it perpendicular to the tear which had happened. And this tear had not extended posteriorly. So that was the second point which played on my mind. So with very gentle manipulation, you can see the tear now very clearly. Is that seen? You can see the tear there. Yeah. So that tear did not extend actually.
Not very clear actually.
No, it will come, sir. It will come. Now you can see, sir. See the flap coming back.
Yeah, it's at 90 degrees to your haptics.
Yeah. So that is where the story ended. I did not do too much manipulation. I did a little bit of gentle visco wash. The lens.
For everyone's benefit, you can keep your mouse there and show.
Yeah.
I mean, like
cursor. Yeah. So this was the area.
Around 2 o'clock area.
Yeah. Now, so for us on table, we were able to place the lens at the desired axis, and luckily did not progress posteriorly. So with with all the stress that was there, this was the result at 2 weeks. So patient had 6/9 unaided in that eye, a little bit of DM folds, but otherwise patient was doing well. But to my surprise, when I actually saw him dilated, so you can see that there is a capsular fusion here. You can see one faint line. So that tear actually got fused. Is that visible?
Yeah.
So that was a surprise, and the rexus, you can see the whole opening of rexus completely intact. The lens was in situ, and luckily the people did it well for me to capture this. And what exactly happened was we had an anterior capsular tear. Tear did not extend posteriorly. Eye will be placed, and haptics, more importantly, were perpendicular to the tear. And at 2 weeks, what we found out that this anterior capsular tear actually spontaneously fused, and slit lamp confirmed the fibrous bridging that we saw. IL, of course, remained stable at that point, and BCVA was on target. There was no compromise. Now, this patient came again for a follow-up visit at 16 weeks. Everything was stable. Little bit of dry eye symptoms were there, but his vision was quite okay till even at that point. And this was the video at 4th month or 16 weeks. So now we can even see that the rexus is pretty nicely round rexus. IOL is very stable. You can see that tear is almost not visible because of the capsular fibrosis that has happened in addition. So this was the post-op, and what is the reason why should it happen actually? So the main thing that we found out was that this is basically there is a loss of lens epithelial cell to cell contact at the tear margin, which actually leads to release of TGF beta, which actually induces these cells to undergo a epithelial mesenchymal transition, and these becomes myofibroblasts, which deposits extracellular matrix, and this extracellular matrix in the form of fibronectin and collagen actually bridges the tear, and that's what helped what we saw in the slit lamp. There is only, with great difficulty, I found out there is only one case report way back in 2008 on this particular tear, which was by Dennis Lam group. Dr. SKR sir was also one of the co-authors of this case report, where they have shown this similar kind of presentation in a 73-year-old who had undergone a single piece at case of IOL. There was a tear at 5 o'clock, and they also placed the lens 90 degrees away from the tear. And their hypothesis was a non-angulated haptics. The capsular apposition happens better, and there was flexible haptics, so there was minimal bag stretch. And hydrophobic acrylic another iron material which actually induces anterior capsular fibrosis because of the shrink wrap effect might be one of the reasons why it actually fused. So we can see this similarity with our case. So this was the tear we can see, and the fusion that you can see on the two photographs. Surprisingly, this was not my first patient. This is another patient whom I had operated in SN 2012. This was a multifocal restore IOL, and this patient came to me for the other eye, and 5 years down the line, you can see that the fibrosis at the tear is maintaining so well. Most importantly, the lens is very well centered, and the anterior capsule opening is also pretty wide. So this phenomena is something probably we can actively look for. A lot of times when the tear happens, probably we don't bother what is happening to the tear, but sometimes this delayed fusion can help in the long-term thing. So from this case, what I think is this is a rare phenomena, but definitely it's possible that it can happen. So mechanism is essentially it's a epithelial-driven mechanism. The material of the IOL is most important. Probably this can happen only with hydrophobic acrylic lenses, non-angulated optics, and most importantly, the capsule IOL apposition is what will drive this fusion to happen. And when you are placing the lens, it's always important that we always practice that the haptics should be perpendicular to the tear. That will prevent decentration and enable fusion. So this was the second case which I wanted to share. So a rare findings for me. It was only 2 cases till now, but something unusual and something good to feel about. Thank you.
Very interesting. Very interesting and very well documented also. Thanks for sharing.
When did you recognize this tear?
Before 2 weeks. No, sir. I recognized it after putting the after putting the lens, sir. Actually,
after putting the lens.
Yeah. So I missed that small nick which was there in the anterior capsule.
During the IOL implantation got extended.
Yes, sir. Yes, sir. Had I noticed it before, I would have actually enlarged the rexus at that point. You know.
No, so you had enlarged the rexus, did
no? If I would have realized that there is a cut, I would have again increased it and made that cut into a regular opening.
No,
but unfortunately, I missed.
What is the reason for the tag?
You think it was a tag from the flax?
I had enlarged it actually. So
no. Actually, Sagar.
Yes, please.
You can comment on this. See, when you have a small rexus, because I do a lot of catalyst flax as well, and especially small pupils. When you have small rexus, don't try to enlarge that in the beginning of the surgery. Okay, because a lot of gas bubbles are there, and you have a lot of cortex will be there, and you will have the your view is not very good. So you all make a slight trench or something like that, and always you make some Durex. Okay, and I'm sorry, echoes there, no?
Somebody's talking, I think.
You put some Japan glue there, so you know exactly where your rexus is, and then use a micro scissors. And when you cut this thing, you use the vanas. What I use a vitreous scissors, the micro scissors, and because that makes a very nice cut. Because sometimes the vanas, you may cut it very little more, and you may not have that control. And always use a micro scissors to enlarge it. And if you use a trip and blow, you know exactly where it is. But do some trench before that. Do some trench before that, and make sure that you remove all the epinucleus and the cortex and the gas bubbles are there, so that the view becomes a little better. And once, of course, you identified the tear only after implanting the lens. If you had identified before implanting the lens, what I would suggest is not to put the lens straight away into the bag. So I put it in the anterior chamber, okay, or on the top of the iris. Then I tuck each the leading haptic as well as the trailing haptic into the bag and gently dial it to the whatever axis you want to. Fortunately for this has been 90 degree away from the tear, so got away with it. I find that this acris of lenses, the fibrosis is more than the Technis lenses and the Hyans lenses. The fibrosis is definitely more, and if you see the anterior capsular fibrosis is definitely there because shrink wrap effect and all other factors. The bio addition is much more with the acris of lenses, especially with the Clarion also the now which is available now, Clarion material. I think all other things are okay, but yeah, sometimes one on that side the fibrosis can occur and it'll start pulling the lens, and it can start decentering. I've noticed in some cases, very rarely it happens as well. But as long as the tear does not go back and across the equator and wrap around the equator, doesn't make a difference. But usually, what small tear? I think the tears, the anterior capsular tears, are more dangerous than the posterior capsular tears, in my opinion. Because especially in flax, sometimes there can be small tears, especially in mature cataracts. Don't try to pull the rexes because many times the free floating rexes. Always put trip and glue and find out because there can be skip areas. If you try to pull the rexes, pull it out, and what happens is skip areas can produce a small flap, and during the phaco, it will extend back, and you can have a PCR and even a nucleus drop for that matter. So these are all the comments I would like to make for this case.
I just did I wanted to ask you one thing.
Yes.
So, is there a way of doing this fragmentation without doing an excess in Catalyst? Do you have an option of that? Because suppose the pupil is very small, and you are saying that you don't want to do Rexis. So can we just do a segmentation and corneal incision without doing a Rexis?
I don't think so.
You tried this before. Is it possible in Catalyst, sir?
I've not tried that, but I think Rexis is necessary in a small.
Even if it's possible, it should not be recommended. So much of bubbles and everything, you're going to increase central ventricular pressure.
Yeah, that's right. So it's going to be more difficult for you to do the Rexis. So if you have a Rexis in a small pupil, it's good. Even if you have about 4.5, 4.3, you can manage a good phaco with that. And at the end of it, you can probably enlarge it after putting the lens also, or before putting the lens, you have better control at that time. So you can do a fairly good phaco in a small Rexis. And the advantage of Catalyst is that it cuts beyond the margin of the Rexis as well. So that is a beautiful advantage of this Catalyst machine. So even the cut will be beyond. So you need to make sure that the central is open. You are going to obviously work only in the center, and you can get away with a small Rexis without any problem at all. So whenever I have a small Rexis, my cutoff is around 5.5 millimeter, because I can get a Rexis of about 4.5 or 4.6 or 4.7 or even 5.2 or 5.3 also I have done, and makes it my life easy because my Rexis is there already. My cutting, the fragmentation is already, and everything becomes very easy for us. Yeah.
So, Sagar, your Rexis you had extended it on the opposite side. When I saw the video, you were doing it on the other side, but your extension occurred at 180 degrees to that, right? So you had gone all around your your Rexis.
If I remember I extended almost about, not in this zone, I think. The other areas I could extend actually.
So
the reason was
from the flax.
There's a possibility. There was a possibility that it might be a tag from the flax. It's a possibility.
And as Sir said that with the Clarion lenses and all Alcon lenses, that thing is the
fibrosis.
Fibrosis is better. Any other comments, PP man, Dr. AR?
Interesting, Sagar. And it's a good explanation also of how this fibrosis occurs. I think one of the prerequisites is that they are opposed. The edges are opposed to each other at the end of surgery. Sometimes a blob of viscoelastic might keep them apart. And then the apposition becomes difficult, and then the refusion might not happen. The other thing I wanted to say was that lens epithelial cells histologically are slightly different from other epithelial cells. It's interesting that they actually have some interdigitating processes. So there is an intercellular, they form intercellular bridges better than other epithelial cells. So even anatomically, they link to each other better. So that, and of course, it's the presence of these cells are important. Sometimes we do overdo the vacuuming and remove these cells. So just the plain basement membrane would not be enough to form the occlusion. You need the presence of some cells for this to happen. So an overzealous removal of lens epithelial cells from the undersurface of the anterior capsule may not have allowed this to happen so beautifully. These were just some comments that I wanted to make.
Thank you, madam. Very nice comment.
Yeah, thank you, madam. That was nice. Sagar, very interesting. Just one thing I was wondering, what was your original pupil, I mean, Rex's size?
So it was less than 4 millimeters, to be, I mean, probably 3.8 or 3.9 millimeters, the original Rexes that I could achieve. But as I told you, that this was kind of my learning curve for the femto cataract. So given a choice, if the same patient happens now with such a small pupil, I'll not do a femto at all. On table, I'll probably have.
Please publish it. JCRS. You have a very well documented 2 cases.
Yeah,
Yes.
we are planning for that.
We can move to the last case.
So if you have time, it's a very short case which I would like to present. Again, a difficult scenario for all of us in practice, preventing negative dysphotopsia. So this was a 71-year-old female patient who had obviously come for cataract surgery. We had planned her right eye first, followed by the left eye. The initial plan was to go ahead and do a Technis Eyehance IOL. So this was the right eye post cataract surgery result. But from the only problem was that day 4, she started complaining of the temporal shadow. And I mean, she was very disturbed by the whole thing. And obviously, we told her about waiting for it because things will settle down, neuroadaptation will happen, and it will reduce like what happens for majority of the patients. So anyway, we had 3 months time before we wanted to plan the other eye. So we just reassured her and sent her back. She came after 3 months, and there was persistence of the negative dysphotopsia in the right eye, and she was very keen for the other eye now because of some issues in the family that they were not wanting to wait. Otherwise, preferably would have waited for the other eye to settle down in terms of negative dysphotopsia and then take her for surgery. And for the right eye, the plan was that let's wait for about a year. If it still persists, then we'll probably think of a piggyback IOL as an option. So I started thinking, what do I do now in the other eye? Should I change the IOL brand? Should I go in for a sulcus fixation placement of the IOL? Obviously thinking that patient doesn't develop negative dysphotopsia. So these are the thoughts that generally, as surgeons, we come across. I think I started doing a little bit of search, and I found out this wonderful paper from Dr. Sam Masket, which basically talks about surgical management of negative dysphotopsia. It's a nice retrospective case study, largest probably published, wherein they had 2 groups. The one 40 patients with 40 eyes in therapeutic group, which already had negative dysphotopsia, where they had some form of treatment, and 21 contralateral eyes in the other group, where it's a second eye surgery. The other eye was having severe dysphotopsia. Now, in this second group, there was they tried what is called as primary reverse optic capture, and they achieved 100% success rate with that. Even the patients who had negative dysphotopsia, they did secondary reverse optic capture, which achieved almost 95% resolution. And these 2 techniques overrided all the other techniques like ciliary sulcus IOL exchange, piggyback IOL implantation. And most failed technique was back-to-back IOL exchange. Just changing the type of lens and keeping it in the bag did not work out. So their key conclusion was that negative dysphotopsia was not IOL material related or edge specific. It can happen in any material, any edges. back-to-back technique doesn't work, and primary reverse optic capture probably is the best technique to do. So I thought, why not implement this in our patient? The reason why this primary reverse optic works is because of the mechanism called as illumination gap mechanism, which was kind of published by Dr. Holliday et al. In way back in 2012, which basically speaks about the ray, red ray, which basically enters the pupil lateral to the optic edge and does not get refracted by the IOL surface, travels undeviated into the vitreous, and basically fails to illuminate the nasal retina, and that is what causes a shadow or a gap. So the reason that is attributed for this illumination gap is an axial space between the posterior iris surface and the anterior IOL surface, which led to this issue. So the bigger the gap, the bigger will be the bracket. So typically, it is larger in patients where we use high index IOLs, thinner IOLs, or lenses with high posterior vault, or patients who have shallow anterior chamber, because the gap will be bigger and the result will be a bigger temporal crescent. So keeping all this in mind, we thought, let's try a reverse primary reverse optic capture in the other eye of this patient. So this was here the main important thing is to get an adequate size rexus, which should be between 4.8, maybe around 5, but not bigger, because you need to bring the optic outside your capsular bag. So here you need to use two instruments. This is a small, there is a little technique, a learning curve in this, where you need to basically bring the optic out from the bag using two instruments on both the sides. So first we have got the inferior edge, now we are getting the superior edge. So it needs a little bit of handling, little bit of control movements to just manipulate this optic out of the bag. The haptics remain in the bag. So essentially you are making the plane of the lens little forward, so as to reduce the distance between the back surface of the iris and the anterior surface of the lens. So this is what the post-op picture looks like. And luckily for us, after doing this procedure, the patient had no negative dysphotopsia in this eye. The other eye is still under follow-up, though there is some amount of resolution of the symptoms, but there is still persistence of the negative dysphotopsia. So the key points here is that negative dysphotopsia definitely can stay even beyond the expected neuroadaptation window. So we have to be aware of this issue, though it's a very small percentage of patients. A lot of times the patient may not turn to you for the other eye surgery because they would be so unhappy that they would have gone somewhere else. So a proactive approach of doing a primary reverse optic capture can be an effective way of dealing with the contralateral eye of such patients. Of course, keeping in mind that we are going to operate a patient who doesn't need refractive correction as well, because if it's a toric IOL, if it's a multifocal IOL, then probably this procedure will not work in that scenario. So this I've done for a few patients, and I found that this is effective, and I thought of sharing this because it's a simple thing. Maybe it adds about 30 to 40 seconds in your procedure, but it can relieve the patient from negative dysphotopsia symptoms in the other eye if you face similar scenario. Thank you.
Very nice.
So, I mean, what did you do for the eye which was operated first?
I'm still waiting for that 1 year to get over. So,
yeah, doing a capsule, I mean, on the anterior capsule,
nasal.
Yeah. So that has been reported to improve. You didn't try that.
No. Because the problem is that needs a lot of that leads to scattering of light a lot. So my worry is that it might add to some new symptoms. So that's why I thought if at all I have to do anything, I'll probably put a piggyback after a year. So that year is still not over. The patient is yet to come to me about for that. And
so
let's see.
Planning for the piggyback.
Yeah. So your experiences on dealing with negative dysphotopsia?
Okay, a very nice thing, because negative dysphotopsia is really a nagging problem, because the patients complain, and especially negative dysphotopsia occurs only if you do a perfectly done surgery. If it's only the capsular bag, you will get the negative dysphotopsia. If you have it in the sulcus, you will not get negative dysphotopsia. And thing what is important is you ask the patient, reassure the patient. I normally wait for 6 months. Yeah, 6 months. Most of the patients, because if you see many literature done by Samuel Vasquez, Holiday, everybody, the end of 1 year it is only 2%. Initially it's about 15%. The end of 1 year it's about 2%, which means that over a period of time it becomes all right. What I found another technique in negative dysphotophobia is you give the patient some other problem. Okay, they'll completely get distracted and forget about the negative dysphotophobia. I've seen this happen. Seriously, I'm telling. I operated on a gynecologist.
Hand it to you, sir.
Yes, I operated on a gynecologist, and she had symphony. I put, and she had negative dysphotophobia in one eye. Then I said, "Madam, you get the other eye also done." Now she said, I'm seeing two rings." I asked her to wait for 3 months and 6 months and all that. Okay. After 6 months, also, she didn't become all right. This is a very practical suggestion. Fortunately for me and unfortunately for her husband developed some CA, carcinoma, and she got distracted totally in the radiation treatment and the chemotherapy for the thing, and completely forgot about the negative dysphoria when she came to me after 1 month or 2 months. So I think it's something which is also functional overlay is also that, because it's a very poorly understood. I used to discuss with Samuel Masket, Holiday, everybody about this negative, what to do exactly. If I have negative, if you are very sure, because most of the patients, if you have one negative dysphotopsia, one eye, most likely they are likely to develop the other eye also, because we do not know exactly where the anterior insertion of the retina and the nasal retina is. Nobody knows. It's very difficult to find out also pre-operatively or post-operatively for that matter. So I have done this polyfocus lens. I don't know how many people have done this. Polyfocus is a lens with a 6.57 millimeter diameter, which is made by Jagdeep Kakadia group from Ahmedabad. It's a it's a it's a very big diameter lens, and it entirely fills up the bag, and absolutely no negative dysphotophobia for that matter. And off late I am doing this femtis also. The femtis, which is a capsular fixation lens. Only thing is you need to do a catalyst about a 5 millimeter what do you call capsular axis, and this it's got small flanges like thing, wherein you just have to keep the lens in on the edge of the capsular axis. So the femtis lens also is a good option for the other eye. So otherwise, the reverse optic capture. The problem with the reverse optic capture with the single piece lens is that, okay, it may not stay there like the regular optic capture with the multi-piece lens, wherein the haptic is in the sulcus and the optic goes into the bag. That gets locked very forever because there is an angulation of the multi-piece lens. But a single piece, there is no angulation at all. So there is a possibility it can come out during the surgery itself. You can see it can come out during the IA. That can be a problem. So I think that's one major thing we have to keep that in the back of our mind. Otherwise, well done, and I think patient is doing very well, I suppose.
The optic in that single piece optic in the, I mean, like iris shaping with that, sharp edge.
No.
There is no iris pigment dispersion.
Till now, I have not seen and not reported also in the literature.
Effective lens distance changes. Did you make any changes in your eye?
Yeah.
It'll be a little more anterior.
Yeah.
I'll tell you one thing. No, Sagar and Shikha. Sorry for the but we used to use a lot of this MA 60 lenses, multi-piece lenses in the bag, long time back, even before the single piece lenses. At that time, we never had this negative dysphotophobia at all.
Correct. Yes, I agree with that. Multi-piece in the bag will never.
Never used to have this. So multi-piece lenses may be a good option.
And also spherical lenses. It's usually seen with the aspherical lenses. So that's what I say. The higher the package, the more the problems.
No, patients, no, they have something to come. They will have 6.5 and 6 vision. They'll say, no, my eyes are irritating. This corner is not good. And this second eye is not as good as the left. This second eye is not as good as the left. So, and then this negative disturb. Then I tell them, your lens is working very well. So, reassure them like that, and
I heard another counseling that you explain to the patient that you're facing all these problems because your lens is working. So then I
Yes.
believe they don't complain anymore.
Absolutely.
But that said, about the optic capture, I would only say one thing, that in the absence of the contact with the PC, the PCO rates will go up.
Yes.
And you have to be careful in choosing the lens power, because there will be a myopic shift because the optic has moved anteriorly. So 2 points there.
Right.
On the other thing which I wanted PP Madam's comment here is, I have seen patients not complaining about negative dysphotopsia if it's a zero spherical aberration intraocular lens you have placed. You see it more with the negative spherical aberration patients. Is there any literature to support this?
With the Envista lenses, no?
Correct. Envista, never heard.
Much.
And I have not read any literature supporting the spherical aberration component of it. But madam, would you have any thoughts on this?
Looking at the the ray tracing work done by Holiday, it is only that peripheral band of rays that cause this problem. The spherical aberration really comes from what the peripheral does in comparison to what this paraxial or the central rays do. So I don't think it has as much to do with the spherical aberration as perhaps the sharp edge of the posterior, sharp edge of these optics. And that might be one of the reasons why we did not see it so much with the old, lenses that Mohan and Sagar were talking about, the old lenses where we never had negative dysphotopsia, possibly because the posterior edge was rounded. Now you have sharp edges to prevent PCO, and that actually aggravates this shadow effect that Holiday was talking about. Another sort of a non-invasive way of doing it. You see, since you know that it is this peripheral band of rays that are causing this, shielding that the side often helps.
The glasses.
Yeah, even having a thicker rim of glasses
Yeah.
would prevent that peripheral band of rays from coming in.
What about anterior capsulectomy, madam? Nasally. Yeah, glazer.
Yeah, I haven't done that.
That has been described.
Few cases. I've done a few cases, and that also works.
I would know that hesitation to damage a ocular excess.
Some echo is coming.
I don't know why echo is coming today.
The one other interesting paradoxical feature about negative dysphotopsia, you would expect that if you dilate the pupil, things get worse. But in fact, with negative dysphotopsia, you dilate the pupil, it gets slightly better.
Yeah, true.
That is correct.
Some people have admitted even dilatation drops.
Yeah. Yeah, but of course, dilatation has its other problems. The overall aberrations increase with dilated pupils. But it's interesting that if you constrict the pupil, as you would intuitively think it would improve things, actually it gets worse because the contrast actually improves. So the patient is able to perceive that difference between the shadow and the well-lit image more clearly. So they actually complain more of dysphotopsia in bright lit conditions when the pupil is smaller. Conversely, it's a paradoxical situation.
Yes, ma'am.
As reduce the dysphotopsia increases.
Nice. We also have Dr. Rajgopal from Scotland. Would you have any comments?
From Scotland.
He's joining us from the OT before
Show your
starting.
face. Yeah.
I think maybe gone for his cases. So, very interesting cases. Now I invite Dr. Mona Khurana to give the summary, the concluding remarks.
Thank you, ma'am. So we had excellent surgeries shown by Dr. Sagar as usual, and very practical and insightful comments by Mohan Rajan sir, by PP ma'am and Ashok sir, and very, very practical points regarding the first case. Always, whenever you have astigmatism and a cause for it, go in for a staged procedure, treat the cause of the astigmatism. Don't be scared to cut the bleb, and especially a sick bleb like that, and revise it. It's always safer for the patient. In the second case, to good surgeons, I think the capsule also bows down, and all tears will join back. So that was very interesting, and all I would say is, and beautifully, PP ma'am has explained the mechanism, how it happens, and please publish it. And finally, handling the negative dysphotopsias, and for example, a yak gap, or even dilating the pupil, and the technique shown by Dr. Sagar and comments by PP ma'am. So there are multiple ways to address it, whatever suits your patient the best, I think, and whatever works in your hand, you should follow. So I would thank everyone for this wonderful session here, and we look forward to the next powwow.
Thank you. Thank you, everyone.
Thank you all.
Thank you. Good night.
Thank you all. Good night.
Thank you, Shikha. Thank you, everyone.
Ashok, let me see your face, yeah?
Sorry?
Sir?
Madam, also, I want to see you, madam.
Okay, I'll take a.
Okay.
Hi, ma'am. What a pleasure
Surprisingly,
to see you.
my laptop says camera not found. I don't know what to do about that.
This command. What is for the screenshot? What is command?
Go to the video.
What is it?
Shift command and 4.
Three. Okay, I'll share.
Great.
Okay, good night.
Night.
Good night. Thank you, everybody.
Mona, Sagar, well done.
Bye, sir. Thank you, sir. Bye.